Good evening to everyone present here with us today. This is Sriyan from IGCP. I would like to welcome all the viewers who join our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Pranto Chakraborty. Sir is MBBS, MD General Medicine, DMB General Medicine, DM Clinical Hematology, ex-professor and head department of hematology at NRS Medical College, Kolkata. Consultant hematologist at Zoho Corporation, Backache. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is what does backache with an M-band convey to the clinician? Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you. So it's always a pleasure to interact with my colleagues. And just as I share my slides, I hope you can see my slides, right? So as the title says, what does backache with an M band convey to the clinician? So at the end of this talk, I hope I'll be able to convince you that M band does not mean myeloma and absence of an M band does not rule out myeloma, right? So let us start with one historical picture. This is what was also known as Chopra test, which is known as aldehyde test, right? So you treat it and you get this kind of a deposit there. And this was supposed to be diagnostic for collagen. I'll tell you what the relationship is with this aldehyde test with the topic which we are discussing today. So let us start with our patient. So AD is a healthy 65-year-old female with no prior history who presents to an orthopedician with a history of recent onset back pain after a minor trauma in a public bus. Now, other than the pain, she feels well and has no other complaints. Physical examination is normal except for painful restriction of bending and tenderness over T12 and L1 vertebra. There was no neurodeficit noted. So she was advised an MRI of the spine. Now, you have to take my word for this. The MRI showed there is a compression fracture, right? T12 vertebra, and it shows a wedge kind of deformity, right? So, what do you think was done next? So, in spite of repeatedly requesting my colleagues to send a CBC, this patient was advised to undergo hemoglobin TCDC ESR. My sincere request to all the listeners today, every lab today uses an automated blood counter. So if you ask for a complete blood count, you'll get all the information. Even if you ask for hemoglobin TCDC, they'll select out those parameters and give it to you. Serum calcium, alkaline phosphatase, urea creatinine, liver function, PT, CT. Let me tell you, CT has died 20 years back, right? So clotting time is of no importance at all. If you're suspecting a bleeding disorder or if you want to do an intervention, please at least get a PT and APTT done. But most important is history. Vitamin D3, serum protein electrophoresis, and DEXA. Well, even the MRI was showing that there was some changes. What happened next was there was this band, right? You can see it on this, and if you do a densitometry, it can be quantified. So this was suspected to be an M band. And that's why she was referred to us, right? Now, what were my concerns then? This is almost 4 years back. Is it a monoclonal gammopathy? I'll define it for you. And is it clinically significant? So M-band, we suspect that still might not be a monoclonal gammopathy also. And is it clinically significant? Do I do something with it? So we will learn, as I told you, what is an M-band, how to look at an M-band, and how to decipher the M-band. So I think you've read this book, an amazing treatise on the final diagnosis and how to look at M protein. Well, don't worry. I use these cartoons to just tell you that, you know, you do not perform an investigation if it is not required. So, what are the tools there? So, I'll be taking on the garb of a biochemist for the next 5 minutes to teach you certain technologies which are used, but you should be aware of as a clinician. Protein electrophoresis, protein immunofixation, serum free light chain assay, immunoglobulin levels by nephelometry, urine protein electrophoresis, urine protein immunofixation, and proteomic study, that is MALDI-TOF, MASFIX, which is the latest child in the block and which is most sensitive. So, as the name suggests, protein electrophoresis is usually done on an agarose gel, basically tries to differentiate the different proteins in the plasma, and based on their electrical charge and the mass, they are fixed and stained, and that is how you get that, right? Now, there is an advanced technology which some of the tertiary care hospitals have in their lab that is called capillary electrophoresis. So instead of an agarose gel, it has a glass capillary, but the essential principle is the same. And while it passes through, you differentiate it. So, what are the usual main proteins which can be seen? Obviously, albumin is the most important, and you have bands which have been named after the Greek letters. So, alpha 1, alpha 2, beta, and gamma, right? And I have just mentioned that these are the things which can happen in abnormalities in diseases. So, if you get a peak in gamma, it can be a monoclonal gammopathy, it can be a polyclonal gammopathy, it can be due to chronic inflammation, SLE, chronic liver disease. Just to tell you that a number of diseases can lead to this kind of thing. Immunoglobulins, even C-reactive protein, is located in the area between the gamma and the beta regions. So, sometimes this can become flat like this, and that is hypogammaglobulinemia, which actually is something where you have immunodeficiency. So, if you use your hand, and that is what I am trying to show you here, right? So, this one, right, is albumin. Then you have alpha 1, alpha 2, beta, and this is your gamma. Today, we are looking at this kind of a band, sharp band, right, which is usually in the gamma position. Now, if you do immunofixation, you will be sure whether it is monoclonal or not. So, what does monoclonal gammopathy means? Gamma spike, it might be in other regions, and it is clonal in origin. That means all the protein has been secreted from the same clone of cells. So they have the same characteristics, and that's why it is so thin and it is peaking like this. Now, if you use antibodies, you will see where the bands are. I'm not talking of this kind of diffuse bands. You see these sharp bands. So this is in IgG and this is in kappa, right? So IgG, kappa. The commonest we have is this kind. You might have IgG lambda, IgA kappa. So just looking at that, you can be sure whether this is a monoclonal protein or not. Usually, this strip is supplied to the clinician by the laboratory. Now, I come to a more sensitive test which was developed at the Mayo Clinic. when you have increased production, you will have circulating free light chains. Usually they are bound with the heavy chains, right? But there is a technology to detect it, which is known as a free light assay. Now it's out of patent, so there are different platforms to look at it. And it has been clearly shown that even in a case of myeloma, SFLC ratio actually predates the abnormal M band, right? So it is more sensitive. Remember this much. And the percentage with abnormal is 100% in light chain myeloma, which might not be picked on just an electrophoresis, 96% for symptomatic, and even in amyloidosis, it is 98%. But it is low in monoclonal gammopathy of undetermined significance. There you might have to use proteomic like Malditov. So if you say that I have to rule out a monoclonal gammopathy, the best combination can be you do a immunofixation or protein electrophoresis with FLC. The sensitivity is close to 99.5%. That is why at the beginning I told you, if you do not find an M band on serum protein electrophoresis, that does not rule out monoclonal gammopathy or myeloma. You should combine it with at least another test, right? So this is what Malditov looks like, mass fix. These are present. Some hospitals have it for looking at, looking at interferons and other markers, but it can be used for looking at proteins also. So this has also been standardized at other cancer center, and we are trying to develop a make in India version of it. Now, this is more helpful because nowadays we use monoclonal antibodies like daratumumab, elotuzumab, even sometimes rituximab and isatuximab. This monoclonal antibodies will also show you a peak. So proteomics helps us by differentiating between the drug and the disease. Now, what do you think I ordered with this kind of information at the back of my mind? So I ordered a serum protein immunofixation and it came as IgG kappa, right? Now, should I do a bone marrow? If you suspect myeloma, then you need to do a marrow. Now, this lady had back pain, had a wedge fracture, and has a monoclonal gammopathy. Even if creatinine is normal, you should do a bone marrow examination, but the bone marrow did not reveal plasmacytosis. By definition, plasma cells, and again, remember, by definition, they should be clonal, right? Because plasma cells can be increased in color. Remember the aldehyde test? So, clonal plasma cells should be more than 10% to diagnose a case of myeloma. Then it comes whether you should treat it or not. So we need to understand the clonality. And how do we understand the clonality? You should never do only a bone marrow aspiration. You should do a bone marrow biopsy. And this is how you should look at it. You look at CD138 if it's strongly positive or other markers are positive. This is clonal plasma cells. Even if they are low in number, if they are clonal, this is suggestive of a plasma cell discretion. Now we did a skeletal survey in other regions like skull, right? Other vertebra and the long bones like the femur and the humerus. So no lytic lesions were detected. Should you stop there? No. We should not stop at x-rays if your clinical suspicion is high, like in this patient. You should either do a low dose whole body CT or MRI for diagnosis and monitoring of bone damage, right? One site of osteolytic bone lesion more than or equal to 5 millimeter, either on CT or PET CT or even on MRI, actually defines bone disease. So we often talk of crab. I'll talk about it. Absence of bone disease on skeletal survey is not adequate for such patients. So, if you find a lesion, if it's solitary, fine, you do an MRI. If it's negative, consider MRI or whole body CT or PET CT. Sometimes whole body MRI and whole body low dose CT is not available, but PET CT is available in most of the cities of India today. So this is the CRAP criteria, right? And what is that? Calcium elevation above normal, renal dysfunction, that means creatinine high, anemia, where other causes have been ruled out. Obviously, the anemia cannot be due to iron deficiency or hemolysis, and bone disease. I told you how to do the imaging. So this is CRAP. But in 2019, we added some criteria because there were some people who would do badly even if they did not have CRAP. And we have added the term slim CRAP. So 60% of plasma cells, light chain ratio affected is to unaffected more than 100, and MRI more than one focal lesion. And additionally, as I told you, presence of 10 or more percentage of clonal plasma cells, or suppose there was a lesion in the vertebra and you did a biopsy while fixing it. Plasmacytoma is adequate also if it is associated with slim CRAP. So then you have a spectrum. Everything is not myeloma. So it is a plasma cell disorder. If the M protein is less than 3, clonal plasma cells is less than 10%, no myeloma defining agents. That means you do not have slim CRAP. It is monoclonal gammopathy of undetermined significance. Now, if the M protein is more than 3 gram or more than 500 milligram in 24 hours, and clonal plasma cells are between 10 to 60%, and no myeloma defining events like CRAB, it is smoldering myeloma. There also we stratify it according to high risk and low risk. I'll not go into the details. But what is myeloma? When you have the plasma cell proliferative disorder and one or more slim CRAB feature. So M band is not equal to myeloma, right? I hope I have made it clear to you. So within MGUS, they can be associated with cancers like myeloma, obviously, macroglobulinemia, plasmacytoma, amyloidosis, light chain disorder, neuropathy, proliferative granulopathy, skin disorders. We have a number of terms now. Monoclonal gammopathy of renal significance, monoclonal gammopathy of clinical significance, right? Inflammatory arthritis, rheumatoid arthritis can be associated with MGUS. But the debate today is, should we call it MGUS or should we call it MGCS? So what is an approach for a clinician? You request serum immunoglobulins and electrophoresis. If all are low or absent, possibly some immunodeficiency. It goes to an immunologist. If all are high, it is polyclonal. Liver disease, sarcoidosis, chronic inflammation, chronic inflammation. If they are high or abnormal, serum electrophoresis, identify a band, and then see on immunofixation and refer to the immunologist. So this is what you do. Now let me come to another patient who doesn't have back pain, but creatinine is high and was referred to nephrology. Analysis showed proteinuria. And on further evaluation, nephrotic range proteinuria, small monoclonal spike, again IgG kappa, and abnormal free light chain assay. Calcium normal, hemoglobin normal. What should you do here? You have to do a kidney biopsy. So if you get a monoclonal band, there might not be backache. But if you see that the creatinine is rising in a diabetic even, but a sudden rise, or proteinuria, you should refer to a nephrologist. He underwent a kidney biopsy And there they saw proliferative glomerulonephritis with monoclonal IgG3 kappa deposits. So you do not find those plasma cells. Bone marrow biopsy was done. No, 5 to 10% skeletal survey negative, and those 10% were not clonal there. So the next step is you have to treat even MGRS with the same regime as we treat for myeloma, right? The patient was treated with cyclophosphamide, bortezomib, dexamethasone. He improved, but 18 months later, he had a relapse. And this is what I tell my nephrology colleagues or my internists, that they should be under a multidisciplinary team where there's a hematologist and there is a nephrologist. So this was the first paper which came in to explain MGRS. So now everything is not MGUS, even if it is not myeloma. And MGRS also has a bad prognosis, right? And there are definite guidelines. So it's a clonal proliferative disorders that produces a nephrotoxic monoclonal globulin, and it is essentially done by nephrologist. You can have smoldering myeloma, you can have smoldering Waldenstrom. I'm not going into all those details. The consensus is that here you do not find like myeloma, but the kidney is affected. It does not cause tumor complications, but you will find abnormal urine. And it's actually a basket of various diseases, various etiologies, and your nephrohistopathologist is the best person to guide you. I'm not going into all these details. You can have organized fibrillary deposits. Recommended are those who have monoclonal gammopathy and unexplained kidney disease. Those with known risk factors for chronic kidney disease but an atypical clinical course. Most of the time we miss it in diabetics. Patients with kidney disease and monoclonal gammopathy less than 50 years of age. You have to do it, right? It is a safe procedure. So what to do in 2023? If you find it, you should complete the diagnosis, the final diagnosis, and treat it. Treatment of the B cell clone, treatment of renal disease, and assessment of hematological response. So what I'm trying to tell you is there is MGUS, there is MGCS, there is MGRS. Your job is to refer it to the multidisciplinary team. So I've discussed about MGUS. They have a 1% chance of developing myeloma every year. So if they're alive for 15 years, it becomes 15%, not very much. I've talked about MGRS. Now I'll talk about MGCS, monoclonal gammopathy of clinical significance, where you can have an arthropathy, you can have skin changes, ophthalmologic changes, and all other things. If you have to look at one slide by not giving your attention to your WhatsApp messages, it is this slide. Remember, the monoclonal protein can lead to a spectrum of disorders. If the tumor is progressing, it can go from low risk MGUS to intermediate high risk to low risk smoldering to high risk to active myeloma, CRAB, and then what happens is extramedullary myeloma and plasma cell leukemia. So there, those malignant plasma cells are not confined to the marrow. It's just like the mafia who do not need the politicians now. They themselves have become politicians. So they become plasma cell leukemia, which has a bad prognosis. We are aware of this, but we are not aware of this. It can lead to MGRS, it can lead to amyloidosis, and it can lead to MGCS and other diseases, which can lead to irreversible end organ damage. So you get the patient here. Keep your eyes and ears open, because depending on how the deposits are there, what type of deposit it is, it can even be point syndrome, right? we have been taught during our undergraduate and post-graduation days. That is also a monoclonal gammopathy of clinical significance. But sometimes we do not know also the etiology, systemic capillary leak syndrome, Tempe syndrome, Schnitzler syndrome, myopathy, scleroderma. But I will restrict my talk to myeloma today, just to give you an idea that the patient goes through this, comes as smoldering. You have to be alert. Newly diagnosed has the best prognosis, goes into first remission, but it's not a curable disease. If it relapses, it goes on, becomes relapse refractory, and might kill the patient. This I have already discussed with you. So, what is our patient suffering from? Our patient actually has MGUS, and you can stratify the risk depending on what they are. And why does she have it? Because 3% of the Caucasian population in Indians, we are doing the study, risk is lower in Asians from Japan. We do not know our prevalence, but increasing age, male gender, family history has a higher probability. So, this is how the disease progresses, and this is what goes on, and that's why we do a FISH to look at chromosomal changes. I hope I have not confused you. I have explained to you what M-band means and how do you look at it and how do you rule out myeloma, MGRS, and other related diseases. Thank you for your patience.
Thank you so much, sir, for your wonderful presentation. Sir, we do have some question if you'd like to take that up.
Yeah.
So, sir, the first question is, what is the appropriate frequency of follow-ups and monitoring? This is our first question.
Of whom? When you find an M-band and if it is MGUS, depending on whether it is IgG or non-IgG. For non-IgG, we usually follow them up every 3 months initially, then every 6 months initially. For IgG, we usually follow them up 6 months initially and then once a year. But be very careful that you're not missing amyloidosis. So please do an echocardiography of the heart, and also if you find that the patient has something, do a pro BNP so that you do not falsely label a cardiac amyloidosis or a systemic amyloidosis as MGS.
Thank you, sir. The next question is, what are the appropriate pain management strategies?
Yes. So the most appropriate pain management study in a patient of myeloma, first is treat it, right? So if you treat it, the patient will become asymptomatic. But if there is severe pain due to a local fracture or something, take the help of the interventional radiologist or the neurosurgeon for vertebroplasty, kyphoplasty, so that they stabilize it. And then your treatment will take care of it. Do not hesitate to use even morphine if required for pain relief initially, but take care that you're also managing hypercalcemia and other comorbidities. If necessary, the patient has to wear a spinal support till the bones are strong, and we always also use the zolidronate or pamidronate if there is kidney failure. And now we have a new molecule called denosumab, but all this take time. These are also used for managing osteoporosis.
There is one last question, sir.
Yeah.
What ethical consideration should be taken into account when using M-band for continuous monitoring?
Ethical thing first is you tell the patient what that band means. And if you've excluded myeloma, assure them that you do not have it now, but you have a 1% chance of developing it every year. That's why you should be on follow up, but you should not wait for a year. If you suddenly develop a kidney failure or something, or the pain increases, you should immediately come to us and we will have a look at it.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, sir, before concluding, any take home message from your end?
Yeah, the take home message is there are different technologies. If you get an implant on electrophoresis, either use immunofixation or serum free light check assay to prove that it is monoclonal. And if it is monoclonal, do not label it as myeloma unless you do the complete workup. And for looking at slim crab, X-ray is not adequate, but measuring calcium and creatinine is very easy. And always take care of the comorbidities because it is a disease of the elderly.
Thank you so much, sir, for joining us today. With your permission, sir, I would like to conclude today's session. Thank you.